Hello, everyone. My name is Abdel Hausawi. I'm a transplant and hepatobiliary surgeon. I'm someone who's very passionate about patient safety. And this is the third episode of Vision Zero. It's a podcast about safety in healthcare that I started a few months ago with the goal of preaching zero harm. Maybe many people do not know that millions of people die from preventable harm in healthcare. Globally, that number could be as high as 5 million just from preventable harm. If you look at a problem like sepsis, which is uncontrolled infection that many patients die from, the numbers are up to 11 million people annually that die from preventable harm. So, let alone that people that don't end up dying, but end up with different kinds of harm, physical as well as emotional, as well as financial harm. So this podcast is just a small attempt to help us move towards that journey of zero harm. So, as I mentioned, this is the third episode. We had a great two guests in the previous episodes, Mr. Jeremy Hunt in the first episode and Ms. Sue Sheridan in the second episode. So with the third episode, I'm going to introduce our great guest. She's a highly respected healthcare leader with strength in turnaround of struggling healthcare organizations, financial, business, and quality transformation of hospitals, board and physician alignments, as well as digital health. She's an alumna of Yale University, a former faculty at Harvard Medical School, a Fulbright scholar, author of several books on patient safety and health information technology, and an international leader in healthcare and health technology. She's a board-certified physician in internal medicine and clinical informatics. Basically, she has served in numerous leadership roles in the U.S., and she is currently appointed as the Chief Medical Officer at Humboldt Park Health in Chicago, Illinois. She served as a Chief Medical Officer at New York City Health Hospitals Cooperation, Kings County Hospitals. And she has received numerous accolades with some notables, including the top 20 Global Women of Excellence from the US Congress back in 2019, Make in India Award by Bharat Nirman Foundation in 2017, Woman of the Year Award by Congressman Danny Davis in 2015, and 130 Women Hospitals and Health Systems Leaders to Know national list by Becker's Hospitals Review 3 years in a row. That's 2013, 2014, and 2015. She, as I mentioned, she wrote a number of books about patient safety. Her books include Patient Safety, a Case-Based Comprehensive Guide that was published by Springer back in 2013, and Health IT and Patient Safety, a Clinical Case Series, published also by Springer in 2016. She was a teaching faculty at Harvard Medical School, Northwestern University, and State University of New York in Brooklyn. She received post-graduation in medicine at State University of New York and a fellowship in medical informatics at Yale School of Medicine. And she obtained her medical degree from SN Medical College in Agra, India, and was a gold medalist in all professional exams. But we have her here also because she has seen the safety situation from both sides of the coin, from an LMIC setting as well as from kind of a US setting. So Ladies and gentlemen, please help me in welcoming Dr. Abha Agrawal. There you go. I thought I lost you.
Sorry,
So, Dr. Agrawal,
yeah.
Basically, it is a pleasure to have you as the third guest on hopefully our never-ending podcast. Hopefully, we will end it once we reach the zero harm. So that's a long journey, and as I mentioned, you have seen patient safety and the safety in healthcare situation from both sides, from an LMIC setting as well as from a US or a high income setting. So what let's just get going with our podcast, and again, as I mentioned, it's an attempt to try to reach zero harm. So everyone has a patient safety story on why they became interested in patient safety. Jeremy Hunt being a politician who is not a clinician, Sue Sheridan being a kind of a non-clinician that came to it from a different angle. What is your patient safety story? How did you got interested in this field?
Thank you, Dr. Halasawi, for a very kind introduction. As I start, I do want to acknowledge and thank you, and I really truly admire your global leadership in patient safety. You and I met during the fourth Global Ministerial Summit for Patient Safety in Jeddah in 2019. And I thought it was brilliant that we were engaging the health ministers as key stakeholders in this movement for patient safety. And it's my honor and sort of a privilege to join you in this movement toward Vision Zero of zero harm for patients around the world. I'm a practicing physician, and I first became interested and intrigued by patient safety truly 20 years ago, over 20 years ago, when the Two Error is Human by the Institute of Medicine was published. Like many of my colleagues in healthcare, especially physicians, uh, I was shocked, I was dismayed, I was rattled by the report's conclusion that over, almost 100,000 people are dying in the US hospitals because of medical errors, because of something that we could have been doing. But once, the initial shock was over, I think it kind of started to lift the veil of silence that had defined the state of healthcare at that time. And I became a student of patient safety. Since then, I have served as in my clinical role, administrative role, and really been a pleasure for me to design, be part of the team to design safe clinical processes, team culture, engaging the boards. And that's kind of has been my journey. I still consider myself that I'm learning and implementing whatever we can, and even if we can save one person's life, that's great. I think the second piece about the patient safety, which is very much tied to my story, is exactly at that time I had started a postdoctoral fellowship in Yale in clinical informatics, and my belief was confirmed that information technology will be critical to improving the safety of care, and as you are saying, achieving zero harm. And a couple of years later, another landmark report came out, Crossing the Quality Chasm, which affirmed my belief, as it said, IT must play a central role in the design of the healthcare system if a substantial improvement in healthcare quality is to be achieved. So really, those are the twin events that intrigued me and sort of took me on this journey toward patient safety. Lastly, I continue to meet leaders, inspiring people, motivators like yourself, like Dr. Berwick, and I think we are only getting started on this journey. And thank you for allowing me to join you.
Thank you very much for sharing with us your how you got interested in this. So we're now almost 22, 23 years since the To Err is Human, as you mentioned. When in your answer, the question is from your practical experience, between both India and the United States, where do you see the level of harm? Is it is it from assessment of the harm? Do you see is it safe to say that it's stable, or is it going up, or is it going down? And from basically prevention aspect, what is going on there?
Yeah, I think that's a great question. Let us assess the state of what we have done and where we have reached. I mean, I see it as sort of a glass half full sort of situation. So a couple of comments here. There are still substantial geographic variation between the progress made, let's say in a country where I have primarily practiced clinical medicine and patient safety in the US, versus, let's say, some low and middle income countries. And I can speak a little bit about India, my home country. So let's maybe first assess what I think progress that we have made, especially in the US and around the world. I think we have made tremendous progress. There is number one, there is an acknowledge and acceptance that there is a problem. As you know, the first step to solving a problem is to at least acknowledge that it exists. Most countries now have a strategy, a policy, some sort of regulation framework for patient safety. May not be implemented, but at least we have it. You are, part of the Vision Zero project. We met, during the ministerial summit, and there were health ministers from all over the world, from Indonesia to Egypt to Maldives to Germany. So that visibility has been created in the last 20 years. A global will has been created. I think in the US, there has been a lot of, public scoring and grading systems like the Leapfrog score or the hospital safety grades. We also have substantial shift to value-based care, where payments have been tied to reporting of hospital-acquired infections and achieving some sort of safe care. So we're moving in that direction. There was the high-tech mandate where $36 billion of funding was awarded to get electronic health records around the country. Although it's still siloed and interoperability still remains elusive, but we have practically become paperless. CPOE is practically universal around the country. So, and lastly, I think more on the intellectual underpinning side, many places are beginning to change the fundamental thinking from individual blame to systems thinking. So those are, in my opinion, major gains that we have made. If I look at the numbers, you are saying, okay, all of this is good. I believe these are at least the US numbers that I wanted to share with you and the audience. The hospital-acquired conditions have shrunk to the record low levels. Went down by 13% between 2014 to 2017, which cut about $7.7 billion in cost and saved 20,500 lives. Before that, in the preceding 4 years, we saw 2.1 million fewer hospital-acquired conditions, which went down from 145 per thousand admission to 115. The most prominent, I would say, visible thing that I see is the rate of central line associated infections have gone down by 80%. In my own hospital, we went 565 days without a central line infection, And we just had one after that many days, about 7 months ago, and again none. That was unheard of. We in my own hospital have not had a catheter associated UTI for over 2 years. And now all of these things were unheard of. So that's the glass half full. Having said that, we still have ways to go. Uh, let's look at numbers again. In the US, now we are thinking it is the third leading cause of death. Top, heart disease, followed by cancer, and now third is medical errors. It used to be respiratory, chronic respiratory diseases, no more. That is not acceptable, that many patients being harmed. And you mentioned globally, uh, hundreds of millions of adverse events, 2.6 million deaths every year, and the societal cost of patient harm about $1 to $2 trillion per year. So that's kind of the glass half full. I think in some ways, to make it even more real, wrong side surgery, everyone can relate to. Somebody, you're supposed to get your right kidney out, you get your left kidney out. Not acceptable. 45 people per week in the US still get wrong site or wrong patient surgery. So those are kind of the things where we have made progress, but we still have ways to go. And maybe if I may, since we are talking about stories, which I'm a major fan of, I think I was very intrigued. There was about one story which is a very popular film actress, who actually unfortunately died in a tragic accident a couple of years ago. At the peak of her career, had the wealth, the fame, and the power. Her mother had brain tumor. She brought her to not one of the best, I would say, cancer center in the US, the most recognized, Memorial Sloan Kettering, right? Was being operated by the chair of neurosurgery. I think we got all the bases covered here, essentially, right? VIP patient, the best organization, the best possible surgeon. Uh, Unfortunately, she got operated on the wrong side of the brain. They kept fishing for the tumor, was never to be found. So the good side is gone because of the surgery. The bad side is gone because of the tumor. She became persistent vegetative state. With all the advances and benefits, the root cause was found to be that somebody, perhaps a technician, flipped the CT scan image on the radiology box in the operating room. So the surgeon got confused between the left and the right. And that's the conundrum of patient safety, that it affects every human life, regardless of your influence, your financial status. It does not differentiate between the wealthy and the powerful and the not so wealthy. And it's the devil is in the detail of that clinical process reorganization. And that's why it is kind of it has been an intractable problem, but nonetheless, I think that's sort of my assessment. A lot of progress yet to be made. We have ways to go, but we have learned so much in 2 decades that if we create a collective will, which I'm sure your podcast is trying to do, there is no reason we can continue to reduce the harm at a much greater rate in the next 2 decades than we have done, because now we have a foundation to build on. We have leaders like yourself, we have champions like me, we have the knowledge, we have the infrastructure around the world. So let's do it.
Great. Well, let me build on your comments about the well, and ask you, why didn't we reach zero harm yet? Is it a lack of will or a lack of skill, or a little bit of both?
I think it's a little bit of both. And my the great thing about, let me step back a little bit. Let's say we hear about war on cancer. You say people continue to die of cancer, and then we establish these cancer research centers to find a cure for cancer. Maybe it's in the genomes, maybe it's going to be the new diagnosis, the best kind of chemotherapy, immunotherapy, surgical technique. The beauty in patient safety harm, which is now the leading cause of death in the US, third leading cause just after cancer, we don't need new discoveries. We know what works. Dr. Gawande's elegant work on checklist. It's a simple paper checklist that anyone in the world can adopt. Does not really cost money. We know what works. The cure is right here. What we need to do is implement it. So that just sort of, but I think number one, the priorities and cultures in different geographic regions are different. I kind of shared with you a little bit about a story where I mentioned, I was I served my Fulbright scholarship time in my home country in a major academic center in the northern part of the country. And my focus was patient safety. I was very excited, enthusiastic. I'm going to go talk with all the physicians, department chairs, nurses, the director, staff, and we are going to improve patient safety. I had a dinner with my cousin, a practicing cardiologist, and his wife. And I was very naively enthusiastic about what I'm going to, I hope and aim to accomplish in 6 weeks. And he kind of just stopped me in my tracks and said, yeah, it's all good, but what about doctor safety? In that context, in his mind, what he's worried about is there's an adverse outcome, somebody's going to come and damage his clinic or going to cause physical violence to him or his staff. So that is we need to understand the geographical context of a particular place, be it the Kingdom of Saudi Arabia or India or US or Sri Lanka or UK. What are the priorities and the challenges in that culture and how you fit patient safety in that? I think one of the big things in my mind, and that will come from the policymakers and regulators, follow the money. If your incentives are not aligned with what you are trying to accomplish, people will focus and prioritize what it is that their incentives are aligned for. That's what happened with electronic health record and technology. We kept trying to implement it, but once the financial incentives got aligned, we were able to get traction around the country. There have to be either penalties or incentives for safer care. I'll take another example. We do a lot of our readmissions in the United States and healthcare acquired conditions in the United States, right? Somebody gets a central line infection. They end up staying 6 days extra in the hospital. Besides the patient harm and the moral, professional, ethical aspect of it, we don't get paid for those extra 6 days. Simple as that. We spent a lot of money, and that gives the chief executive officers, the chief financial officers, the entire organization an added this becomes a priority for them. On the other hand, in a fee volume and fee-based, daily per diem fee-based healthcare system, what does it matter if a patient stays 6 days extra? Because you are able to charge for those extra 6 days. So I think alignment of payment incentives, it feels a little bit like, well, it has to be beyond that. The motivations have to be ethical and avoid harm. Absolutely. But let us put our money where our mouth is, so to speak. So that is a second piece, I believe, is an extremely important piece. I think the third piece, to answer your question, was, is it a lack of knowledge or lack of will? We do know in a large measure what works. I talked about checklists. I talked about simple, low-cost thing called hand washing. We know it works, right? Dr. Semmelweis showed us at the cost of his own life that hand washing works, right, in preventing infections. So we need to have a playbook, if you will, to roll out and implement these practices. Say these are low-cost, low-hanging fruits. Everyone around the world can do that, regardless of where you are located. And I think that's another reason why we haven't been able to achieve this much. That's why I was very impressed when we did the ministerial summit. It's kind of my third reference to that. Let's get the people who drive these changes at the national level involved. I may be as passionate about patient safety, but if my there is no political will in the country to do that, my efforts are not going to pan out. So great to have Mr. Hunt as your first speaker. We will need to create that political will from the top down in order to get traction on patient safety. You are on mute, Dr. Halasawi.
There you go. They say that the most common phrase in 2020 was "you're on mute." So
yeah, that's right.
I basically was on mute and continued on mute. So
right.
That was a great segue for my next question, which is, the past days, and we've witnessed this COP 26, in Glasgow, Scotland, about the climate change. And the thing is, I want to ask you now, and to try to kind of think about this in forward-looking, in a positive way, how can we reach zero harm? The past 20 plus years have seen a great effort and great work towards bridging the knowledge gap. I think when it comes to the implementation gap, the gap still exists. So before you answer this question, I just want to even put that in a context that I ask our viewers also to do, which is go and ask within your family and within your network about climate change. I've done that. I've asked my mother, I've asked my siblings, I've asked my kids. So 3 generations. You ask 10 people through different generations, you get 10 yeses that they've heard of the climate change. You ask the same 10 people about safety in healthcare, about patient safety, I guarantee you're not going to get that 10. And this is where the delta exists. So we have an advocacy problem, or lack thereof, at regional levels, at national levels, at global levels. It would be, I always say that global climate change is a big problem, and something that needs to happen to it. But believe me, those countries that have contributed to this summit and the previous summits and all the different agreements, those different stakeholders, many of them were pulled into this kicking and screaming. And the reason is because there's been enough, kind of a critical mass of people saying that we're destroying the planet for the next generations. So when it comes to safety in healthcare, and I think this is maybe the language that we need to start using, because the safety is not just about the safety of patients or the safety of healthcare workers. This is not a zero-sum game. It's actually a complementary effort. So we need to kind of look at it as a collective safety. So when it comes to safety in healthcare, I believe that we can we need to kind of do more to help towards to solve the advocacy problem. And again, I just want to hear from you. I mean that it would be a dream, hopefully come true within the next years, that moving from the Global Ministerial Summit series on patient safety, we can move to global summits where we have heads of states, not just ministers of health, because we need to have all those different stakeholders. And I think I want you also to address in your question, in your answer, the co-production piece and how we can get family patients and their families also to contribute to this, because I believe that is an important part of the equation, if you agree with me.
Absolutely. So it's a lot. Let me try to tease it out sort of in
Unsecond.
a few things. I completely agree with you about the concept of total system safety. It's no longer just patient safety, it's system safety essentially. And sort of, I think if you I believe IHI has been pretty much at the forefront of the Institute for Healthcare Improvement to say to expand the definition of preventable harm to include physical, psychological, emotional, moral, economic, and societal harm to patients and to the workforce and their families. So really, the concept is very much there, and that's what we need to embrace when we go toward Vision Zero. So that it's not a zero-sum game. Uh, Let me take your second point about engaging the patients and families. We believe patient is one of the most underutilized resources in healthcare, and ultimately, if we engage them, they absolutely would be, because it's their lives, their families' lives. I've, sort of been a not a patient. I've been a patient. I actually wrote about sort of a blog entry a couple of years ago. I was a patient for a couple of years for a minor issue. But my father, who is in his 80s, he's undergoing some medical issues right now, not hospitalized, but it's been interesting to see him going to a couple of cardiologists, an ophthalmologist, and a pulmonologist actually in the last week. And he's in India. I'm coordinating his care. I'm his care coordinator and social worker right now, besides being his daughter and a physician. And I can tell you, everybody gives him different medications, duplicate medications. Nobody has any idea what the cardiologist gave. If one inhaler, the other person is giving the same inhaler. There's a total lack of care coordination. We are giving theophylline, two different doses simultaneously. I just wonder, if I were not doing it, what would happen to his health? And obviously, 99% of the families in the country, in the world, would not have a person, a physician, a child doing it for them. Obviously, could have engaged. They could have engaged them. So I think I'm just witnessing it firsthand these days as to how important it is to engage patients and their families to design safe systems. I think what I want to think about it in terms of patients, I give it a lot of thought. We have always been taught as physicians, you and me, first do no harm, right? The basic tenet of us practicing and us doing patient safety. What I'd like to say is first ensure no harm. You get into a hospital, and I'm saying you are empowered. It should be a deliberate, intentional thought in your consciousness. I can be harmed, and it's my duty to ensure that there is no harm. It's not happening. Like when you go to a hospital, there's a gift shop with flowers and teddy bears and what have you. Let's put a book there. You are checking into the hospital. Here is a handbook. Look out for these things. Has your doctor washed hands? Has your nurse washed hands? So on and so forth. Even something as simple as that. I think it can be done. It must be done. Otherwise, we are not going to achieve Vision Zero just by that's your co-production of care. Make patients, and families is that partner in that care. Having said that, I think the challenges are going to be cultural. In any society, uh, there is an inequity in power structure between the clinical team and the patients. They are very vulnerable. They believe their life is in your hands, and they are hesitant to question your decision making. And that problem is very much exacerbated in societies that are based on authority or hierarchy. They just don't. I've had these conversations with some people in my own family. No matter how educated, I said, "Yeah, you are going to have a surgery. You can ask the surgeons, how many operations like that have you done in the past?" No, we can't ask that. He will or she will be offended. We ask that. So that is the groundwork we are going to have to lay to get patients and give them empower and give them the resources. I think at some point of time I would like to kind of write a patient's handbook for patient safety, not for you and me and for the heads of the state or the health ministers, but for patients all over. Ask your doctors, have you washed your hands? Ask how you sterilize your trays. Question your medications. Demand to get your list of medications, so on and so forth. So that's the patient aspect of it. I think the third thing that I'd like to say is, and I mentioned quite a bit, that you have to start aligning your reimbursement systems. Whether you are a single payer, UK, Canada type of system, whether you are a complex multi payer system like in the US, which has its own challenges, or whether it is more out of pocket cash reimbursement type of system like I see back home in India, you have to align payment incentives. Uh, and maybe if the governments won't do it and the hospitals won't do it, I, as a consumer, will need to demand that. Why can't there be a consumer coalition? Because if if the US government via Medicare is paying my hospital and demanding that I not cause hospital acquired infection because they are paying for this care, fair enough. But if in a country like India, consumers are paying out of pocket, let there be a consumer coalition demanding hospitals to share their data about patient care, about hospital harm, and demand that they not cause harm. So I think a softer approach is helpful, which we have done over the last 20 years. I think we now need to have a greater level of accountability on care providers, especially where it hasn't happened. Is that kind of hopefully we have a lot more accountability in the US, and I believe at least this is a system I know much more deeply. We have made a lot more progress compared to, let's say, another country where I can compare in India, where we have made less progress because that accountability isn't there. Uh, so, on the one hand, we need to drive the underpinnings as a professional, moral, ethical, societal justice imperative, but the implementation has to be based on accountability, both for providers and the financial accountability, if that makes sense. And whoever is paying for that care, whether it is the insurers or the government, or if it's the consumers, then let there be a consumer coalition. So I'm a pretty strong believer in both carrots and stick kind of approach. I think,
Absolutely.
yeah, the third thing, I am a huge enthusiast. I have a tremendous enthusiasm about technology usage. I know you are a sepsis leader globally. They really, we can do so much with the background surveillance now with artificial intelligence, with predictive analytics, that we should be able to substantially give care providers the data and information they need in order to act quickly. When I see sepsis harm in healthcare organizations here in my own hospital, it's the timeliness of the action is still the biggest barrier. Did I have comprehensive data about this patient in a timely fashion so that I could have taken action, a comprehensive action timely, whether administration of antibiotics or looking at the lab reports and so on, or for that matter, admitting to ICU. So that's sort of another thing in technology. But even if not that advanced, I think CPOE, the computerized physician order entry, should become universal. Low income countries, middle income countries, high income countries, The curse of illegible handwriting is unacceptable. Hundreds of thousands, millions of people are harmed just because people can't read doctors' handwriting. A decimal is misplaced. You give medications that are interacting. I gave you my father's example. God knows how much theophylline, perhaps 4 or 5 times the tolerable dose of theophylline he would be taking for his COPD if I were not there to intercept that. And that's we can. So I would argue for no handwritten prescriptions anywhere in the world. Let's create low cost handheld solutions that can work on anyone's smartphone. It doesn't have to be a complicated $1 billion epic Cerner implementation. That is the madness we do in the United States. But it could be, a few dollars a month solution. So anywhere in the world can do CPOE on their mobile device using some sort of a solution. So um, I think the third piece, I believe, which I would like to be a part of the solution moving forward, at least I'm thinking about it, a simple longitudinal medical record for a patient. Simply having all my labs, all my medical problems, all in one place so that I know what's going on with me. My doctors know what's going on with me. We make decisions in the vacuum of information. I'm trying to say that for us to realize the vision of zero harm, what we are going to need is universally applicable solutions that we need to be able to roll out on a mass scale, low to middle LMICs as well as high income countries. And of course, last but not the least, I think the measurement systems around the country. What we don't measure, we can't improve. I don't know what's going on in patient safety in many parts of the world. When I did some research even as late as yesterday. I wanted to see. I know the stats about US because I can find them. I don't know the stats about. Then everything else is bunched into LMICs. That's really, there are countries with 10 million population to countries with 1.3 billion population. I have no idea what's going on there. And so really those are some of the things that, we kind of as a global leadership community work with stakeholders around the world and took immediately implementable low-cost solutions and then continue to build on them. I absolutely think we can, and with the mindset of zero harm, that any harm is unacceptable, we can realize that vision. So that's sort of what I'd like to sort of call on everyone else and contribute myself toward that vision.
I think that's a great kind of collective solution, and just listening to you, you mentioned accountability, which is a key word. So that kind of fits into the category of the culture of safety, and there's a lot that we can learn from high reliability industries. I don't think we're doing enough in healthcare. My brother is a pilot, so I know a thing or two about aviation. But any consumer knows that this is the safest industry on the planet, and there's a reason. Culture of safety is one of them, because safety in aviation is religion. Safety in nuclear is religion. Safety in oil and gas is religion. Safety is not religion in healthcare. In 2019, there were estimated almost 39 million flights throughout the globe. And that was the same year that the Ethiopian airliner, the 737 MAX 8, actually crashed. And it was just preceded by 5 months before with another crash of the same type of airplane, the 737 MAX 8, from an Indonesian airliner. And it took only 2 flights, 4 or 5 months apart, for the aviation industry to ground every 737 MAX 8 throughout the globe. I remember I was having a conversation with Mr. Jeremy Hunt, and I think even we talked about it in the previous podcast, that in an advanced healthcare system like the NHS, it was estimated that 150 patients die every week from a preventable death, which is the equivalent of an airplane crashing every week.
Yep.
And again, just to remind everyone, it took only 2 crashes 4 months apart, not in one country, but in the entire planet, to ground an entire fleet of an airplane. This is how, responsive and how serious the aviation industry about safety. And we really need to learn a lot from them. And just to build on that, you've touched a number of parts, that I believe need to be part of the solution, because you talked about the fact that the accountability, but then you say that we're lumping LMIC under one category. I would say we're lumping, healthcare is a complex adaptive system. So when we lump all hospitals under one roof, even within the same city or within the same state or within the same hospital, I think that doesn't do service to the next patient who could potentially be harmed. And I believe one of the things we need to do is we need to redefine safety in a personalized way. So the definition of safety now, patient safety, is the absence of harm. But that's a kind of a one-size-fits-all definition. That does not help me, does not help your father, does not help the next patient who potentially could be harmed. But if we personalize that definition and say that safety is the absence of harm for every patient at every point in time and place. So then if you think about the next patient who's being admitted for a hip replacement, then he or she is, like, we're thinking we want to make sure that they're safe throughout the journey. So if it's a 2-day, 3-day admission, then we think about it before they get admitted, throughout, and afterwards. We think about it while they're in the on the bed, while they're in the toilet, while they're being wheeled down to the operating room, on the OR table, afterwards. And I think having that definition, then you mentioned, technology. I think technology could help us a lot. We in healthcare, we're not asking the right questions. So in aviation, if harm happens at step 10, they intervene at step 1 and 2 and 3, So they are so they're not even comfortable with the level of safety. They keep pushing the envelope all the time. For us, if harm happens at level 10, at step 10, we intervene at step 9.5. So many times at step 12 and 13. Exactly. So we're always looking, backwards. And I think one beautiful thing that you mentioned is, and I think to link to the co-production is, what if we before at every encounter of a patient with the healthcare system, try to be proactive and think about, like, having a patient safety consent. So that patient who's being admitted for a hip replacement, we know from historical data for that age group, for that hospital, these are the top 5-10 potential harms that could happen. And then we co-produce a preventative approach to, from a risk management of, like, how we not end up having harm for that individual. This is what myself as a patient and my family unit can do, and this is what we can do. And what if we celebrate, those successes? Because people say zero harm is not attainable, which I totally disagree with. And it tells you something about the culture. Because within a shift, we could actually reach zero harm if we define that this is the potential harm that could happen. But think about using IoT, the Internet of Things, with, like, sensors that knows where the patient is, where where the healthcare people are, getting input from different sources. Add on top of that AI and machine learning, and then we're actually moving upstream towards the time that we can do something about it. You talked about sepsis, and the timeliness of intervention is important. We're still in many hospitals using early warning signs, and the question is, are they early when you have physiological changes that are affecting the vitals? That I argue they're not early, and I think if we leverage technology and AI, we could buy 12, 18, maybe 24 hours upstream to really not end up in the situation. So I'm just commenting. I mean, this is not a question, but I'm just commenting on the points that you mentioned, and I wonder if one thing that we need to do is we need to really do innovation and in the healthcare provision. And when people hear innovation, many of them think high tech. Doesn't have to be like the innovation in the healthcare provision. Some solutions that could work in a low and middle income setting as well as in high income setting. And I think the idea of a patient safety consent at the time that the patient is being admitted. So this is where we have an opportunity, because when we intervene later, I mean, if the patient falls, too little, too late.
That's right.
But if we have technology, and if we ask of the industry, the technology, the right questions of how can we eliminate patient falls, or at least how can we eliminate harmful falls? So then you can start thinking, maybe kind of putting the falls risk assessment in on a machine learning platform. Then you can think of having certain paddings and certain flooring for different individuals. So even if they fall, they would fall on something that would not end up making big damage. So you start thinking in a different way. But we're not asking the question of, okay, these are the top 5, 10 harms. How can we make sure that they never happen in a co-production way?
Yeah, absolutely. I mean, the irony is we can do interplanetary explorations and probe to Mars and man on the moon, 40 plus years ago. And I cannot prevent still a person falling to the floor, a patient, and hitting the head and having an intracranial bleed because they were trying to reach the remote to change the panel, to change the TV channel, or they were trying to hit the call bell to call a nurse. This is just, it should be unacceptable, right? What good is all this technology to that individual and his family or her family who ended up dying or having a brain injury because they were simply trying to change the channel? We're sitting in my home right now. All I need to do is press a button on my remote or or call Alexa to say, "Hey, Alexa, take me to CNN," and Alexa will take me to CNN with me not having to move my hand. And why don't we have a conversation with the creators of Alexa and, as an example, all the people who are doing, and ask them, guys, let's all commit around the world. Nobody's ever going to fall, like you said. Nobody's ever going to fall. Tell me, from the flooring to the IoT sensors to the voice enabled technology, what it is that we can do. I'm sure we can come up with reasonable cost solutions. Some of it has been this coordinated. I think you said this very eloquently in the beginning. What you permit is what you promote. We have tolerated that. We have tolerated airlines, aviation industry decided not to tolerate. The world as a community decided we are not going to tolerate airplane crashes. And somehow this same world has decided it's okay to let patients continue to die. I think maybe it's less dramatic. Nobody knows when an airplane crashes. in broad daylight, fantastically and spectacularly, everybody can see the flames. When that individual falls to the ground or somebody gets a catheter associated infection, it's in the silence, it's the suffering of silence. There's nobody there to see and know, and it's all hidden behind the complexity of healthcare, and nobody knows, did they die of their illness, of the congestive heart failure, or did they die of the infection caused by the catheter, or did they die because of the fall? And it's all hidden behind the complexity and in silence. And hopefully these conversations will start to peel the onions, the layer of the onions, and say we refuse to tolerate that. Our patients and our society will have to tell us as doctors and healthcare providers and our elected officials and leaders to say we refuse to tolerate that. I think I'll come back to this, and I've thought a great deal about it. We must engage patients and families in telling us, in saying to us through their consent, patient safety consent. That's a great innovation. I'm going to think more about that. We refuse to tolerate harm. What are you
I think basically, on that point that you mentioned, I believe if we advocate, so the whole global advocacy, because safety is local. Safety happens at the bedside. Safety happens at the interaction between patients and families on one side and the healthcare system on the other side, either in the outpatient setting or at home healthcare setting, so it happens at that level. But the global advocacy, I believe, will make it mainstream, because I believe we still did not make safety mainstream for two key stakeholders. One is the healthcare professionals, clinicians like you and me, because many clinicians think that people that talk about safety are in like a cult-like groups.
Yeah, right.
Safety, harm happens to other patients. It doesn't happen to me. In my practice, how many times have you heard in my own practice, that arrogance of physicians that they carry out with. And the other mainstream is the public. So I mentioned in 2019 that 39 million flights took place. Imagine if the aviation industry was like us, not saying 10%, not even saying tolerating 1%, but tolerating 0.1%. You would have ended up with thousands and thousands. When I did the math, it was like basically 30,000 crashes. If you did 0.1, if the airline industry tolerated 0.1% out of the 39 million, you're talking about 39,000 crashes. But the airline industry does not tolerate that because they have this mindset of zero harm. Whereas you have many of the leadership within the healthcare system, and at least that is something that we need to eliminate. Having someone, a leader in a healthcare system saying, it's okay to have 10% of patients being harmed. Tell me the next time that your family member is in the hospital if that's acceptable to you, because to patients, the numbers are a bit confusing to them. It's either 0 or 100%. They no one is going to the hospital to be harmed. So to any harm to patients is unacceptable. And if what we need to do, and I think that's another part that, from a culture perspective as a healthcare system, we need to kind of help patients help us with the co-production, because we need to be the proactive in making, as you said, in many cultures and many places, patients would be concerned about, upsetting the the physician, that they don't like. So we need to try to really advocate for the co-production, but then not just talk about it, but just do the nuts and bolts. Okay, so how can we think about different aspects? But I think from an advocacy perspective, I believe if many people learn about this problem, we can actually crowdsource solutions, because we're leaving the discussion about bridging the implementation gap in a very, very tiny sliver of the healthcare system, tiny sliver of the population. I think if we push this problem and have global grand challenge about safety in healthcare and crowdsource solutions, how can we prevent healthcare associated infections, specifically how can we prevent catheter associated urinary tract infections, or ventilator associated pneumonia, or what have you. You would have very, very exciting, because on one end, people are going to say that's not acceptable to us. And then that is going to create enough momentum to actually come up with some innovative solutions that are crowdsourced by the entire, so global problems require global solutions. I think the only thing that we didn't do in the global patient safety movement is we said, we can do it alone. And we come to these meetings on an annual basis, and it's like an echo chamber. We basically, I've never been to these meetings where people don't agree on 99% of everything. But where are the other voices? Where is the industry? Where is the average person? People within their own settings, they could actually come up with innovative solutions. If you tell them these are the potential harms, then they start thinking in an innovative way, because we as human beings, we're entrepreneurs. We're always, just give us a problem to solve, we solve it. And especially when you have a family member that is involved.
Absolutely. I think this is great. I love the idea of global grand challenge and crowdsourcing, and let's have all voices, helping us together create a solution, because it could be my family member and your family member and my mother or father or your brother or sister the next time that there is a harm.
Absolutely. So I know that we've taken a lot of your time. You've been very generous with your time. I'm supposed to be the moderator, but I get excited about this. So I'm channeling some of these thoughts as we're talking. But any final thoughts you have regarding the vision towards zero harm? And when I say zero harm here, it's not just zero harm for patients, but zero harm for healthcare professionals as well.
No, really, in the final, I believe not only we can accomplish this, I believe we must accomplish this. We owe it to our patients, our families, ourselves. They are second victims. We are also second victims of when a medical error happened. So we owe it to the patients, the families, and ourselves as healthcare professionals, as patient safety advocates, to embark on this journey towards zero harm. And it would be my pleasure to partner with yourself and other leaders around the world to contribute toward that vision. And thank you.
Fantastic. So, Dr. Agrawal, it's been it's always a pleasure to talk to you about these issues. I'm honored and privileged to be contributing to your upcoming book in patient safety. And hopefully, as we're keeping these conversations going with on one end, showing the magnitude of the problem, and on the other end, trying to engage more and more people from outside the tent, make the tent a little bit bigger that is talking about this. I'm a believer that we will find solutions and we will transform safety, as we're moving forward. So I'm optimistic, and I would end this podcast on a positive note. So thank you very much.
Thank you.
Okay. Take care. Bye.